Bismillahirrahmanirrahim. Well, you have been through this session, started with the really ischemic digits. You have been through the muscles, and you have traveled through the blood and had antiphospholipid and gone through all the organs, multi-organ disease, and now you have come back to the heart and large vessels. The good news is this is the last talk, and another good news is it's a very short talk. So, I'll just go through very quickly. Vasculitis, well, a heterogeneous group of clinical syndromes characterized by inflammation of blood vessels due to cellular infiltration, and the clinical picture essentially depended upon the size and extent of blood vessels. The sequence of vasculitis is due to luminal occlusion. As we know, stenosis or occlusion can cause ischemia and infarction, or due to changes in the blood vessel wall, which can cause necrosis, aneurysmal dilatation, thrombosis, and hemorrhage, ischemia, and infarction. So these are the various pathological underlying phenomena. There are lots of primary vasculitic syndrome which we'll discuss today. The secondary vasculitic syndrome also occur, and they are very common, but they are usually associated with other connective tissue diseases, and the diagnosis is usually obvious because of the manifestation of other diseases. I'll discuss the primary vasculitic syndrome very broadly. First of all, they cause ambiguity of clinical presentation, difficulty in diagnosis. There are limited diagnostic tests, and there is difficulty in obtaining tissue for the diagnosis. Therefore, they are difficult to diagnose, classify, and a lot of overlap occurs. I'm going to talk about the one which affect the aorta branches, is Takayasu's arthritis and femoral arthritis. But there is a long list of large and medium vessel arthritis, such as polyarteritis nodosa, Schuch-Steyer's, isolated sinus vasculitis. There's medium-sized vessel arthritis, again the same group, plus Wegener's, then small vessels and venules. All these, I'm sure, have been covered already somewhere in the conference. There's variable incidence because of difficult to define different subsets. But Kawasaki's disease, we know, exclusively affect the pediatric population. Takayasu's, the young people between 15 and 25, but most of the others, they affect the fifth decade of the life. There is again considerable overlap in the pathological features. You can see here that there's almost everything: fibrinoid necrosis, polymorphonuclear infiltration, lymphocytes and monocytes, eosinophils, and they have got different overlap in different conditions. So they're really not really pathognomonic, except that giant cell usually suggest the giant cell arthritis, and also present Takayasu's arthritis, where the tissue is usually not accessible, but these are pathological findings usually present. So serology, again, there are limited number of tests like ENCA or the serological test for the primary disease if it's a secondary vasculitis. But for majority of the others, there is no specific antibody tests. This radiographic evaluation does help a lot. There's conventional angiography, CT angiography, and MR angiographies. We should be careful about disease that mimic vasculitis, including infective endocarditis, as Dr. Gibson and Dr. Niket have mentioned, streptococcal infection, DIC, atrial myxomas, amyloidosis can resemble, and cholesterol emboli and drug abuse. So I start with a patient of mine. He is Mr. A. Khan, who is 21 years of age. He presented in 1997. He is a BBA student, and he has been unwell for a year and has been to almost all renowned physicians and specialists. He presented with kind of an extensive swelling on the left side of the neck, with a history of malaise, irritability, tiredness, especially after manual exertion. There's no history of as such claudication. The swelling was pulsatile on examination on the left side of the neck, and we could immediately see that he had an absent left radial, the right one was weak, and he had normal heart, but there was definite bruit under the left clavicle and over the left side of the neck. He had a long list and file of previous investigations, And I just summarized that he had an ESR which ranged between 55 to 95 for most of the last 1 year. And all the other anti-ANA, anti-development DNA, ANCA, and all serological tests were done, RA factor, etc., etc. They were all normal. He had normal counts and normal biochemistry, including renal and liver biochemistry. He had one angiogram done as well, which showed narrowing of the carotid artery with post-stenotic dilatation and also left subclavian and slight narrowing on the right side as well. He received a very haphazard treatment in the past, wasn't compliant with it. He wasn't sure of the diagnosis. He was given different versions. When he first came to us, we had gone through, had further tests done. Our radiologist suggested a repeat of his MRA of the whole body, and he confirmed that yes, he has got Takayasu arthritis involvement of the upper limb blood vessels. There was really no involvement of the renal or lower limb blood vessels or the other part of the aorta. So we started treatment with 30 milligram prednisolone. He responded very well, and over 1 year or so we were able to taper down the dose to 10 milligram. And azathioprine was started at 65 kg, 125 milligram a day, and it was decreased to 100 milligram as he was complaining of hair loss. But he was well settled on this dose for some time. He also had a systolic hypertension measured in the femoral vessel, which was 150 by 100, and after giving diltiazem, a slow release 240 milligram a day, he responded well and his blood pressure was better controlled. Now, during the follow-up, he has had various changes in his pulses. Sometimes the pulse was palpable, like systolic 70, something like between 70 and 100 on the left, and slightly more on the right side. There were bruits always present. There has been femoral cuff used for hypertensive monitoring. We have been doing ESR, but the real question was how long should we continue the treatment? How should we monitor the lesion? How sensitive is MRA or other tests? But the radiologist recommended what I did. Initially they suggest whole body Dopplers, color Dopplers, and they were able to comment that yes, there's slight increase in the wall thickness, but that was so arbitrary. How can you be very sure of the treatment, just like you can actually be sure of CRP monitoring or ESR monitoring when you are sure that this is